Okay, second. Okay, actually, go for it.
Hi, everyone. So presenting asthma in the public healthcare. Today will be me, Dennis, and Akshay. We're presenting our biopsychosocial approach to the management of asthma. So briefly, we're going to do a quick introduction to asthma before we get dive into the biopsychosocial approach. What is asthma? Asthma is a chronic inflammatory disorder of the airways in the lung, characterized with reversible airway obstruction. It has got quite a variable presentation and symptoms. It occurs in susceptible patients after they've been exposed to various triggers, which may be environmental, infectious, and depending on the patient. And they usually present in acute exacerbations due to poor chronic control. So it's very important to get good control in the public, in the primary healthcare setting. Worryingly, there's been an increase in prevalence of in studies done in South Africa that have shown that the lifetime prevalence and the 12-month prevalence of wheezing increased in clinical trials in South Africa from 27.7% to 33%, and from 6 actively. These same studies also showed that South African children with asthma had more severe symptoms and worse outcomes than those same patients, but in more high-income countries. So we believe that a biopsychosocial approach is necessary in the management of asthma. So first, just on the biological note, so how do we diagnose asthma? Of course, we have to use history examination investigations. A typical history for an asthmatic patient is usually a young patient, usually almost always below 20 years of age. They present to us with fever, with features of allergies such as hay fever, eczema. They may have a positive family history. Their symptoms are intermittent, so they have periods when they are asymptomatic. And they have certain periods during the day when they are when their symptoms are worse. On examination, depending whether the patient is chronic or presenting to you in acute exacerbation, they typically present as hypoxic wheezing patients who are short of breath and tachypneic. But diagnosis is made on can be confirmed on investigations. So you use peak expiratory flow rates. So a peak expiratory flow rate, an improvement of greater than 20% than that of the pre-bronchodilator peak expiratory flow rate, about 20 minutes after using salbutamol, can confirm the diagnosis of asthma. It's important then to divide the patients into different groups depending on their severity. These are mild intermittent asthma patients, mild persistent asthma patients, moderate persistent asthma patients, and severe persistent asthma patients. And then how we do this is that we use daytime symptoms, nighttime symptoms, their peak expiratory flows, and then we can manage these patients depending on which of those categories they fall into. Management in general, lifestyle modifications important. They need to be counseled on avoidance of triggers and avoidance of triggers and anything else that may cause them to have an asthma attack. Otherwise, then their treatment is broken down into relievers and controllers. So depending on whether they're intermittent, mild, as you can see in our picture, whether they're intermittent, mild, persistent, moving up to the more severe patients, there's a stepwise approach in the management of these patients. It's important to also, I think at this point we needed to mention is inhaler technique, because what we have encountered in the clinics is that a lot of the asthmatics have very poor inhaler technique if you ask them to actually demonstrate to you how they use it, and caregivers of the children also have no idea how to use them. So there's quite a bit of information available on EM guidance on this. There's quite a good table that describes how to counsel patients and caregivers on proper inhaler techniques. So if we have patients like that in the clinic, we can have a look at that.
So then moving on to the psychological aspect of asthma. The psychological variables do affect the outcomes of asthma due to its effects on treatment adherence and patients reporting their symptoms adequately. So when patients have poorly controlled asthma, they can have major effects on the patient's lifestyle. They can have increased anxiety and stress. They may have exclusion of social environments. This can be even taken in the form of self-exclusion due to fear of an attack. And especially with younger kids, this impacts them with playing sports, playing with friends. And I think sometimes it's also forgotten that the caregivers also have increased levels of stress and anxiety. They worry if they're not around for attack, whether their children are carrying around their inhalers or not. And also increased visits to the clinic do place an increased burden on the caregivers. There have been studies, especially in the first world, that show depression is common amongst uncontrolled asthma, leading to worse outcomes. But very few of these studies showed that actual treatment of anxiety and depression showed better outcomes for the asthma. So basically, for the psychological aspect, it seemed evident that improved control of asthma reduces the psychological impact that it can take. With regards to the social aspects of asthma, we've mentioned how it can affect social exclusion, but there's also significant environmental and social issues that can impact asthma management and control. A lot of the patients we see in our setting come from low-income households with small homes. This pretty much leads to a higher chance of overcrowding, smokers in the household, allergens, biomass exposure, indoor fires, which all increase the triggers and a worse control for patients. Although saying this, urban areas are also not immune. There's increased pollution in these areas. There's still smoking, pets, and all those sort of things, which still play a role in the social aspect affecting asthma. So pretty much in conclusion, asthma is quite a common disease that we see in the primary healthcare clinic, and it is a treatable illness. If uncontrolled, we've shown that it shows significant impacts in the biological, psychosocial aspects of the patient as well as their families, and that good control based on these measures in the primary healthcare setting can not only reduce the effect it has on these patients and their caregivers' lives, but also the burden on hospital admissions around the country. Cool.
Thank you, Akshay and Dennis. You've actually used a report in documents, in fact, guidelines from the US and dated in 2007. Any thoughts from anyone else about the source of information? Any reflections on some of the presentation? Anybody would like to share? Are you happy?
Hi, Prof.
Hi, Yuval. Yes, go for it, Yuval.
So actually, there's new guidelines that were recently released in 2020. It's by the Global Initiative for Asthma, and so they recently changed it. I don't know when it was, but I remember when it was still with students, and they're saying that actually they initially used to recommend SABAs for mild asthmatics, but they actually found that now they recommend, and they actually showed that there was no prevention for it in the long term. And so they're recommending that all adults and adolescents with asthma should receive inhaled corticosteroids.
Yeah, I think that's been a growing phenomenon of using corticosteroids. How would you say that's different from what has been for a while?
Well, now for patients with mild, so either step 1 to 2, can be purely controlled with inhaled corticosteroids. They don't need SABAs.
Well, and you say that's in the Global Initiative for Asthma. I haven't seen that, but thank you for sharing that. I'm sure that people pull it up if you just Google Global Initiative for Asthma. I'll have a look at that. I think one of the challenges I would imagine is trying to look at guidelines, and that's the topic that we talked of last week. And I'm hoping that people got clear that when we're looking at guidelines and we look at evaluating evidence, we've got to ask ourselves, is it evidence and is it contextual? In other words, are we looking at South African guidelines? And if we use global guidelines, what's the difference and why the difference? Now, you've pointed out a difference that is being considered rather using inhaled corticosteroids more earlier in the treatment of asthma than would be than we usually do. One of the challenges in our setting, and perhaps we could just talk about that. What is the challenge in our setting to do that? I'm not suggesting that we shouldn't do it, but I'm not sure that in South African guidelines that's coming through yet. And we would like other experts within our country to actually reflect on it, but you're experts. So what's your thought about that in our context? And Akshay, I think firstly, you said it was asthma in the public service. Primary healthcare, PHC, is not about the public service. It's about primary healthcare, and it is applicable in the public service as well as the private sector. And in fact, what you've suggested is quite commonly the advice given in the public service, private sector, and justifiably so. You have patients that are much more educated, much more able to manage. You need to think in both circumstances. So do you want to, does anyone else want to respond? And I'm going to start calling names out if you don't offer yourselves. Any thoughts on what you've all raised in our context, and what do the guidelines suggest? And where do we resort to? Which guidelines do we start using as a first measure, first step? It's important to go there first, and before you think about global or US guidelines. Akshay, Dennis, where should you have gone first?
So we probably should have assessed more local guidelines first, more applicable to our population rather than looking at overseas guidelines to start with, and then probably assess the two and then sort of looked at how we could apply it in our settings.
Absolutely. Please, I mean, these are not exercises in just taking up some guidelines somewhere and just putting out a very short presentation. We give you half an hour because we expect you to have some thought behind it as to exactly what you're doing it. So just do put some more effort into it. The current guideline you should be resorting to, which is the first local guideline? What's your resort to for local guidelines?
So most of the information we got for the presentation, we used the National Department of Health. So we looked at what is available on their resources.
Which is
that. I mean, I don't have the guideline with me. We're just using
the EDL.
We're using EDL, yeah.
Well, I mean, EDL has a different take to what you suggested. So in terms of that, the EDL actually talks of mild, moderate, mild, persistent, moderate, persistent, severe, persistent asthma, which is slightly different to what you presented, but important for you to see how the local guidelines actually spell it out. And I think that is an important point that is being raised. Certainly, we want you to appreciate something very important about the South African guidelines. And in the South African guidelines, short-acting beta agonists, as SABs, as was just mentioned now, are actually your first option, even in the mild, intermittent, mild, persistent. In fact, I think that if you're having a patient who's intermittent with less than 2 episodes per week, to put them onto, as Yuval has suggested, onto corticosteroids, what do you think? Mild intermittent asthma, would you put your patient in Shawelo or Lilly Ngoyi on that?
Well, I mean, on the we've got EDL with us, and the EDL says that it recommends a SABA. So yes, salbutamol used when to control the symptoms.
Right.
But personally,
So
I think the majority of the people we've seen in the clinic have been on steroids and inhalers.
Mm-hmm. I understand. The point is that, would you put the patient yourself on these as a start? Because that's what Yuval is suggesting. And we just want to try and understand, yes, start with, and the learning point is start with the local guidelines, understand them. Make sure you understand them because there's a lot of thought gone into them, so you use them better. But at the same time, it's improving, but the challenge with the South African guidelines is that the evidence base does not translate into that very quickly. They do consider it. It's actually being considered much more frequently now that it's an app online. The written form used to be only updated every 3-5 years, which is really long. So guidelines on the app is happening more frequently, which is great. So it's actually becoming a better resource. But understand that there might be differences between good practice globally and what is guidelines in South Africa. Okay. Yes, but the thing is, you have to ask yourself, what are the challenges with using it? So what's been your experience when you've seen these patients to put that to say, what, let's use corticosteroids on with it. Would you do that with your patient in Shawelo? That's my question. Would you do that in your private practice in Santon?
No,
the 10-year-old
guidelines that we have available, we wouldn't.
Well, you wouldn't do it in the public service, partly because of guideline, but partly also because the context differs. So if you're dealing with patients that are coming from Soweto, you might feel, would I do it? Because the patient in themselves may not be able to use it properly. I don't know whether you've been looking at it, but I think every one of you who sees an asthmatic patient should tell the patient, demonstrate your technique to me. And that's an important point in primary care, which you should have dealt with, which is really why we said asthma in primary care. What are the issues around it? And asthma, the inhaler technique is a really important part of the problem. So what as an exercise, I want each of you, the next time you see an asthmatic, a couple of asthmatics, ask them, show me with your pump how you take it. And then to ask them how they take their pumps, being very clear about the difference between the salbutamol, the green or blue pump, and the brown ones. And you'll see the corticosteroids. You'll see the challenge that they use it poorly, they don't use it well. They also don't use it in the way they should have been using it with the corticosteroid every day. They tend to slip into using it as a reliever, which is not what it is as a controller. So you need to actually check that. And then if you look at them, ask them the question, do they gargle afterwards? So this is some of the challenge in some of the question Yuval is talking about in guidelines. So think about that. I think you've raised a number of issues. And I think in terms of management, I think that increasingly the use of longer acting beta agonists are becoming used in the private sector in South Africa. And it's in fact common to see that happening. But in the public service, that's quite expensive. It may happen and you need to be aware of it, but understand the labs, then how they're used in the private sector and understand that there's a place for it, but it's context driven and resource driven. But there are other challenges that I think in your overall management, and context bothers me a lot. So I want to point out to some other people, and I'm going to scroll and pick up people randomly. Carlota, would you like to share, what do you think are some of the gaps in what has been presented on the contextual issues in asthma management, asthma assessment and management? Thanks, Carlota. Waiting for you. Carlota. Carlota Sekokane. Okay, Jessica Willemser, do you want to offer your thoughts on, in the context, if you're dealing with an asthmatic in primary health care, what are the challenges, what are the issues that you think you need to deal with in this in a patient? Jessica? Carlota disappeared. Maria, do you want to offer? I'm going to call out names because if you're not participating, I think this is going to be part of the challenge. And I think we're going to start noting people who do not respond because you can switch on. And I'm sorry, Maria, give me a second. I think that those who do not respond on the email and been asked are going to be deemed as not participating in this meeting. And we are going to note this, so please be attentive. Maria, go ahead. Thank you. What are your thoughts?
So something that I've come across quite a few times with asthmatic patients, this is adding to what you said about methodology, is I've had some patients who it wasn't explained to them when they actually need to use the pumps, like the brown and the blue. So I had an adult asthmatic who she said she was diagnosed as a child and she hadn't used her medications in 5 years, and she uses the brown one as an reliever, which it isn't really what it's for. So I think just when we are prescribing newly diagnosed asthmatics, just to make sure they really understand that they have to take it twice a day, that they have to use it correctly, even if they're not symptomatic, because she felt that if she wasn't symptomatic, there was no need to use her pump.
Absolutely. I think that should not be for people who are, you might say, newly diagnosed. You should do it for everyone. Any asthmatic who walks through the door, even though they look quite competent, please go through their medication. You'd be surprised. Some of them have drugs, oral, theophylline still being prescribed long-term, oral steroids. So there's a lot of challenges. Please don't just simply prescribe, repeat, and then check their approach with their pumps. They're not using it very well. So, but Maria, when I talked about contextual challenges, any other thoughts or anyone else? I'm going to wait for the two people I asked to speak, Carlota and, have they disappeared? Carlota has left. Okay. And I asked for Jessica. Jessica, you're still here. Jessica?
Hi, Prof. Can you hear me?
Yes, thank you. So what in the context do you think is
so
challenging when you're dealing with primary healthcare asthma? I mean, this should be really all of you should be thinking about. Go ahead.
Well, firstly, I'd just like to say from a personal perspective, what I haven't done with regards to asthmatic patients is to advise them to wash their mouths after using the corticosteroid asthma pump. So that's something that I can improve on personally.
Okay.
As I'm sure maybe many other people can as well.
Sure. Okay.
In our context, I know most of the patients that I've seen are on both the corticosteroid pump as well as the reliever, the SABA asthma pump. And I don't think that the majority of the patients know when to use which pump, which is a problem which has already been discussed. And also,
what about the context?
How to use the pump specifically as well.
We're not going to go into. Yeah, don't worry, Jessica. We can't go through everything in asthma. We just need to pick up some key issues that are important in primary care. And we've talked about technique and leave that aside. I think we've done it enough. There's certainly a way which we need to talk about technique, but I'm concerned about context. In other words, when you're dealing with a patient comprehensively, asthmatic is a particularly important one from context. Do you have any thoughts? No? Okay. It's fine. Thank you, Jessica, for responding. Matthew O'Reilly, you're here. Please tell us, what do you think in terms of context that is important in the next 2 minutes, and then we'll close.
Yes,
thanks, Matthew. Yes, go for it, Matthew.
Can you guys hear me?
Yes.
So sorry, my kids are also running around like Michelle.
No problem. No problem.
I was just thinking
talk
from
louder.
a context perspective, maybe I'm thinking more biopsychosocial, not really on the medications front. But just like from an access to sort of like a biokineticist, just to lose weight. I mean, I see a lot of patients that are these asthmatics, they're overweight, they're quite large, they've got no access to gym, they've got no access to, you know, an exercise facility, a good dietitian, you know, just someone to sort of assist them just to lose a bit of weight. Because objectively, you lose a bit of weight, they'll cut down on their GERD. So they'll, you know, obviously that's obviously aggravate their reflux. Their reflux is going to potentially aggravate or exacerbate the asthma. You know, if they're going to do more exercise, and if we slowly build them up in a controlled manner, they'll then, you know, increase their exercise intolerance, will decrease the exercise intolerance, be more tolerant to exercise, and potentially that can also aid them. And even if you look at like the type of exercise, like for asthmatics, like swimming, a lot of our patients can't even swim. I don't know if you've ever, like a lot of the biokineticists recommend swimming. So how many people have access to that? Cool.
No problem. I think the thought about strengthening their respiratory capacity, good, and I think that's fine. I see Bhaveen's, thanks Matthew. Bhaveen, you've got your hand up. Hopefully you've got the answer I want. Yep, Bhaveen, go ahead. Yes.
Good afternoon, Prof. So I just thought that maybe we could also mention, and I think Akshay did touch on it with regards to like the biomass fumes in the house, and that a lot of the time we neglect to address what the triggers may be during the consultation. For example, if like I know last week I had a patient and it was a new child who came in, newly diagnosed asthmatic, and they couldn't figure out the exacerbation. And after a bit of like inquiring, we found out that he had carpets throughout the house, probably that hadn't been vacuumed and were retaining dust mites and things like that. So we should just always consider the triggers when it comes to asthma, I think.
Very much. And I think this is about the fact that why context matters, why contextual history is important. And it's not something you know, context is not just like, tell me about your life and your wife and everything in between. It's about having a targeted approach. You will need to think about what is the key clinical problem in asthma. How do I deal with it? I mean, you should remember from your teaching around asthma, a reversible bronchoconstriction that comes from some sort of allergen or some sort of atopy, and you need to see that as the problem. That usually asthma is a part of a complex of conditions that are part of atopy, where the person is overreacting. And so you need to look at, well, you know, do you have other problems? You know, they might be sitting with a conjunctivitis, allergic to conjunctivitis. You don't look. You don't ask about other allergies, other atopies, nor do you explore in the family, are there any other people with that? And that's just because you're managing the whole family. You don't know that other people don't realize they could be treated, both medically, but also by way of interventions of prevention. And this is really important. You can have this asthmatic and he's coming here repeatedly. All you're doing is you're upping the medicine, but you're not looking at really what's going on. And the truth is he's sitting with carpets thick of dust. And you don't address that problem. So think about all the triggers, all the things that can cause, all the allergens potentially. And one of the big ones, you should be doing allergen testing in patients, depending on the context. In private, you might get that done easier. But then what you do is nine times out of 10, it is in fact dust mite allergies. And that's easy. So even in the public service, even if you can't do allergen testing, talk to the patient, listen, if you want to help this process along, tell me what is exactly going on at home. Is there carpet, thick couches, thick curtains? These are potential problems. So you need to deal with dust across the house. And that means, you know, full-blown clean, take things out, hang them in the sun, dust them outside. This will not only help you, it'll help the whole family, especially if there's atopy in the family. So it's a major improvement in the family, and you're just not treating the patient with medicine. So think about house dust mite in all your patients, but there are other allergens potential. So, you know, there are minor grasses and pollen, and those tend to be often when you ask them, they will tell you it's seasonal. Their aggravations are seasonal. Sometimes asthma is also aggravated by exercise. You need to listen to what makes it better, what makes it worse, and is there seasonality to it? And if not, your big challenge is house dust mite, and that takes some explanation. It's not just a simple thing. You've got to talk about removing it, even vacuuming, and that's if they have it, they can clean it or take it outside, beat it, wash it. hang it in the sun, make sure it's beaten if it can't be washed. So this is the kind of advice that you need to keep in mind. So I hope that you guys have that. Troy, yes, you want to contribute before we move on to the next one? Good, Troy, go for it.
Hello, Prof.
Thanks,
Thank you
Troy.
so
Go
much.
ahead.
I
Yes.
wanted to just ask, I mean, looking at the guidelines and how asthma is diagnosed, I don't know what your clinical experience is with it, but I haven't found a spirometer or anything in the clinic I'm at. So I don't know if everyone else is just empirically making the diagnosis or...
Listen, I think that many a time, the question to ask is, how do you make a diagnosis? Most times, a patient will come in with a, let me explain to you. I've got a spirometer, spirometer in my rooms, but many a times I don't use it. And its use is where I'm having a consistent management of a patient. So in terms of diagnosis, it's reversibility. Yes, you can check by saying, well, you're having the asthma now, let's see, or you've got this shortness of breath. Let's take a puff and you blow, and then let's do nebulization and see if it's reversible, because that's the diagnostic in a way. And then you might use it to say, okay, after that, every time I see you, I want to use that as a measure to see what is your capacity as it goes through, month by month with treatment. Are we improving? Are we getting it back to normal? And you could use that as a measure. But I don't think that it's that you can't get good, reasonable quality care by just managing the patient clinically. And the way to manage that clinically is that often at time we do that. We listen, we find squeezes, and if we want, we do the nebulization and find the wheezes gone. But really the most valuable, tends to be most valuable tool is the patient telling you, I'm improved. The big danger in that is that the patient is in fact not completely improved, and they don't know what being without wheezes means. So that's something of a challenge. And that's where I would say, if you feel that I listen and there's wheezes and the person is telling me I actually feel better, then I would pull up my spirometer. And it's not a spirometer, it's a metered dose inhaler. It's the sort of, what do you call it now? Is it spirometer? The peak expirative flow rate, the peak flow meter. So that's what you're looking at. So I think you don't really use spirometry in asthma. I don't think it's your resort to. It's certainly, if you have it available, you'd want to use it, similarly to the way in which you use a peak flow meter. So I think you can finesse it as you go along, but it's not an essential. So don't think that you're compromising in providing good quality care. Was that all right, Troy?
Yeah, thanks, Prof. That cleared it up.
Okay, good. So let's go to the next topic. But